Welcome to the deep dive. Today we're really getting into the weeds on one specific condition, Marfan Syndrome, often just called MS.
Yes, Marfan Syndrome. It's a fascinating, almost textbook example in pathology of how one tiny fault, a single gene defect, can cause such widespread and, frankly, devastating problems throughout the body.
And that's the paradox, isn't it? People with Marfan can look quite striking, very tall, long limbs, long fingers, almost elegant, you might say.
That's true. There's this appearance of, well, structural sort of extravagance.
But underneath that, there's this profound internal fragility, a weakness that often targets the body's biggest, most vital blood vessel.
Exactly. So for this deep dive, we're leaning heavily on core pathology texts, really focusing on the genetics, the molecular side of things.
Right. Our mission today is to figure out what actually happens when the body's connective tissue, its structural glue, starts to fail. And maybe more importantly, how has understanding the tiny details of that failure changed how we treat it? Are we moving beyond just managing symptoms?
That's the crucial question. First, let's get a handle on how common this is. Estimates put it around 1 in 5,000 people globally, which for a single gene disorder is actually relatively common.
And it's passed down in families primarily.
Yes, it's mostly an autosomal dominant condition. That means you only need one copy of the faulty gene inherited from one parent to actually have the disorder.
So that explains why we see it run in families so often.
Yeah.
The sources say something like 70 to 85% of cases are familial.
That's right, passed down through generations. But, and this is important, for the other 15 to 30%, it's caused by new mutations, sporadic cases.
Meaning it can just appear in a family with absolutely no prior history.
Precisely. It can pop up unexpectedly. And the penetrance is high. If you inherit that gene, you're almost certainly going to develop the condition.
Though how severe it is can vary quite a bit, right?
Massively. The clinical expression is highly variable.
Okay, let's dig into that foundation then. Before we paint the full clinical picture, what's the single starting point? The one protein defect that causes everything from the height to the dangerous heart issues.
Right. So the main culprit here is a mutation in the gene that codes for Fibrillin dash. The gene name is FBN11.
FBN1. Okay.
And it's a big gene located on a specific spot, chromosome 15q21.1.
Fibrillin 1. Let's establish what that's supposed to do when it's working correctly before we get into what breaks.
Good idea. Fibrillin 1 is basically the main ingredient for making microfibrils. These are really important sort of cable-like structures you find everywhere in the extracellular matrix, the stuff between cells.
So if collagen is like the body's concrete.
Yeah, the stiff stuff.
Yeah.
Then Fibrillin 1 microfibrils are more like the high tensile elastic cables within that concrete. The rebar, maybe?
Providing strength, but also flexibility, resilience.
Exactly that. They form a scaffold, they give tissues integrity, help organize them, and critically, allow them to stretch and recoil without damage. Think about tissues under constant stress.
Like the aorta, with blood pumping through it constantly.
Perfect example. The aorta wall, ligaments in your joints, even the tiny little fibers, the ciliary zonules that hold the lens of your eye in place, they all rely heavily on these fibrillin microfibrils.
So logically, if your Fibrillin 1 is faulty or you don't have enough,
then the mechanical strength in those areas is just compromised right from the start, leading directly to the kinds of systemic failures we see in Marfan syndrome.
okay, that's the structural problem. But you mentioned genetic defects. How many ways can this FBN1 gene actually go wrong?
Oh, it's astonishingly diverse. The sources mention nearly 1,000 different mutations have been found in just that one gene.
1,000. Wow, that's huge genetic heterogeneity.
It really is.
So how do we make sense of that? How do all those different mutations end up breaking the scaffold? Are there general mechanisms?
Yeah, functionally we can kind of group them into two main types. The first one is simpler to grasp. It's called haploinsufficiency.
Haploinsufficiency.
Okay, remember, it's dominant, so you have one good copy of the gene and one bad one. In haploinsufficiency, the bad mutation basically means you just don't produce enough normal Fibrillin 1 protein.
So the cell's only making maybe half the amount of building material it actually needs.
Pretty much. The result is that the tissue just doesn't have enough microfibrils. It falls below the structural threshold needed, and so the connective tissue is inherently weak. It lacks density.
Okay, that makes sense. Simple shortage. But you said there's a second mechanism, one that's often worse.
Yes, and this one's more insidious. It's called the dominant negative effect.
Dominant negative. Sounds bad.
It usually comes from specific types of mutations, like missense mutations, where the Fibrillin 1 protein that gets made isn't just non-functional, it's actively harmful.
How so?
Well, this abnormal protein still gets produced, but when the cell tries to assemble the microfibril, the polymerization process, these faulty protein subunits actually get in the way. They interfere with the normal fibrillin chains that are being made by the healthy gene copy.
Ah, so it's like throwing bad ingredients into the mix. It doesn't just dilute the good stuff, it actively ruins the whole batch.
That's a great analogy. It sabotages the whole assembly line. So the resulting microfibrils are much more dysfunctional than if you just had a simple shortage. This often leads to a much more severe clinical picture, more severe disease.
Okay, so we have weak structure from not enough material, or a really faulty structure because bad material messes everything up. That structural idea was the main thinking for a long time, wasn't it?
For decades, yes. But then came a really transformative discovery. Fibrillin 1 isn't just a structural protein, it's also a regulator.
A regulator, what does it regulate?
This is the dual mechanism that really changed our understanding. Besides forming the scaffold, Fibrillin 1 microfibrils play a crucial role in controlling a very powerful signaling molecule called transforming growth factor beta, or TGF-beta.
TGF-beta, I've heard of that. It's involved in growth and inflammation.
All sorts of things. Normally, the microfibrils act like a storage depot or a sponge. They bind to TGF-A, keeping it sequestered and inactive in the tissue.
So fibrillin isn't just cable, it's also like a parking brake for this potent chemical signal.
You could put it that way, yes. Now, in Marfan syndrome, when the fibrillin scaffold is defective or deficient because of the FBN1 mutation, that storage system fails. The brake comes off, the sponge leaks.
And TGF-beta gets loose.
Exactly. You get abnormal, excessive, and sustained activation of TGF signaling, especially in places like the aorta wall.
Okay, runaway signal. What does too much TGF-beta actually do that's so bad in this context?
Okay.
Especially if the main problem seems structural.
Well, this excessive signaling unleashes a cascade of damaging effects. It's not just passive weakness anymore, it's active tissue destruction.
Active destruction, what does that look like?
It promotes inflammation. And critically, it ramps up the production and activity of enzymes called matrix metalloproteases, or MMPs.
MMPs, molecular scissors.
Pretty much. They're designed to break down and remodel the extracellular matrix. But when TGF-fipnoling goes wild, these MMPs go into overdrive. They start aggressively chewing up the remaining matrix components, collagen, elastin, everything.
So the faulty structure is being actively dismantled from within.
Yes. Plus, the excess TGF-β messes with the vascular smooth muscle cells, which are vital for the aorta's strength and tone.
Wow. Okay, that connects a lot of dots. That dual hit, a poorly built structure plus this corrosive chemical signal actively eating away at it, that explains why the damage can be so severe.
Precisely. And it helps explain things that were harder to attribute just to simple mechanical weakness before, like the bone overgrowth, why Marfan patients are often so tall. TGF-β is a growth factor, after all.
Right, and maybe things like the myxoid changes in heart valves.
Yeah.
That softening and thickening.
Exactly. That excessive signaling contributes to those changes, too.
Okay, so with that deep molecular picture, the faulty fibrillin and the runaway TGF-beta, let's look at how this plays out in the clinic. Where do we see the effects most clearly?
Well, the most obvious signs are often the skeletal ones, what we call the Marfan habitus. Patients are typically unusually tall. They have what's called dolichostenomelia, long, slender limbs. Arms and legs seem out of proportion to their torso.
And the famous long fingers and toes.
That's arachnodactyly, or spider fingers. Very long, tapering digits. There are even bedside tests for it, like the wrist sign.
Where they can wrap their thumb and pinky around their other wrist and overlap them.
Correct. And the thumb sign, where the thumb sticks out way past the edge of their clenched fist.
And besides just length, there's that hypermobility, right? The double-jointed appearance.
Yes. Joint laxity is very common. It's again due to the weak fibrillin in ligaments and joint capsules. They don't have the normal tensile strength, so joints can bend way further than usual. This can lead to chronic pain, dislocations, and even early arthritis.
What about the rest of the skeleton? Head, chest, spine?
The head shape is often distinctive dolichocephalic, meaning long and narrow from front to back, maybe a prominent forehead or brow ridges. The chest frequently shows deformities like pectus excavatum, a sunken or funnel chest, or sometimes the opposite, pectus carinatum, a pigeon chest.
And the spine?
Spinal problems are really common because the ligaments supporting the vertebrae are weak. So you see kyphosis, a forward hunch, scoliosis, a sideways curve, or even vertebrae slipping out of place, spondylolisthesis.
It really is a system-wide failure of the body's internal scaffolding. So if we see that externally in the skeleton, I assume we see similar failures internally, like in the eye?
Absolutely.
Wow.
The eye findings are crucial for diagnosis. The most characteristic sign found in maybe 60% of patients is ectopia lentis.
Ectopia lentis, dislocation of the lens.
Yes, specifically bilateral subluxation or dislocation. Usually it's partial, meaning the lens hasn't completely detached.
Subluxation. Okay, and it shifts in a particular way.
Typically, it shifts upward and outward. This happens because those tiny ligaments holding the lens, the ciliary zonules, which are rich in fibrillin, become weak and stretched. They just can't hold the lens centered properly anymore.
And why is that specific finding so important for doctors?
Because bilateral ectopia lentis, especially shifting up and out, is pretty rare outside of Marfan syndrome. So seeing that, particularly alongside a family history or other signs, is a very strong clue. It points you strongly towards an MS diagnosis.
Okay, skeletal signs, eye signs. But now we need to talk about the really dangerous part, the cardiovascular problems. This is where the mortality risk really lies, right?
Without a doubt. These are the most life-threatening aspects and account for most premature deaths if the condition isn't managed properly. The absolute core issue is the progressive breakdown of the wall of the ascending aorta.
The aorta, right near the heart. What's happening inside that wall at the microscopic level?
The process is called cystic medianecrosis. Essentially, the middle layer of the aorta wall, the media, which gives it strength and elasticity, starts to degenerate.
Necrosis means death, right?
Mm-hmm.
So the tissue is dying.
Parts of it are, yes, the smooth muscle cells die off, the organized elastic fibers fragment and disappear, and they get replaced by these pools of unstructured, sort of mucoid or gelatinous material. Cystic spaces form.
So instead of a strong, layered elastic tube, you get something weakened, spongy, almost disintegrating.
That's a good way to picture it. And this profound loss of structural integrity in the media leads to two main, potentially catastrophic outcomes. First, the weakened wall starts to stretch and dilate, ballooning outwards.
Especially the aortic root, the part right above the heart valve.
Exactly. As the root dilates, it pulls the aortic valve ring wider. The valve leaflets can't close properly anymore, leading to aortic incompetence or regurgitation. Blood leaks backwards into the heart.
Which makes the heart work much harder.
Yeah.
And the second catastrophic outcome.
That's the ultimate fear, aortic dissection. The weakened, dilated wall is incredibly vulnerable to tearing. Usually a small tear starts in the inner lining, the intima.
And then the blood pressure forces its way in.
Precisely. High-pressure blood surges into that tear and literally splits the layers of the media apart, creating a false channel within the aorta wall itself.
Oh, wow. Like delaminating the wall from the inside.
Yes, and this dissection can rip downwards, sometimes along the entire length of the aorta, cutting off blood supply to vital organs.
In the final event.
Often aortic rupture. Either the dissection tears all the way through, or the chronic dilation just reaches a point where the wall bursts. It leads to massive, usually fatal internal bleeding.
That's terrifyingly clear. We also hear about mitral valve prolapse being common. Is that the same underlying weakness?
Yes, very common, maybe 40 to 50% of patients. It's the same issue, deficient fibrillin in the valve leaflets themselves and the little cords, the chordae tendineae, that anchor them.
So the valve gets floppy.
Exactly. The leaflets become thickened, excessively billowy, redundant. When the heart pumps, they bulge backwards into the left atrium instead of sealing shut. This causes mitral regurgitation or leaking. While it's usually less immediately dangerous than the aortic problems, it can definitely lead to heart failure over the long term.
Okay, so we have this huge range of potential problems: skeleton, eyes, heart valves, the aorta, and you mentioned earlier that the severity varies wildly. Someone might have terrible aortic issues but look relatively normal otherwise.
Absolutely. That variable expressivity makes diagnosis challenging. You can't just rely on one feature.
So how do doctors put it all together? Is there a standard approach?
Yes, diagnosis relies on a formal set of guidelines called the revised Ghent criteria. It's quite a sophisticated scoring system.
What makes it sophisticated, not just a checklist?
No, it's designed to account for that variability. It
Yeah.
looks at major and minor criteria across the key systems, skeletal, cardiovascular, ocular, plus skin and dura, and integrates that with family history and, importantly now, genetic testing results.
So you need a certain combination of findings.
Right. For a definitive diagnosis, you generally need major criteria in at least 2 different organ systems, plus involvement in a third. Or you need to find a known disease-causing FEFBN1 mutation, plus have one major systemic feature, like aortic root dilation.
It really treats MS as a spectrum, needing a points-based approach. And that complexity, that understanding of the underlying molecular issues, Seems to have really driven changes in treatment, hasn't it?
That's the really exciting part, the pivot in management. For years, the main strategy was just trying to reduce the physical stress on that weak aorta.
Using beta blockers, like atenolol.
Exactly. Beta blockers slow the heart rate and reduce the force of contraction. The idea was purely mechanical. Less pounding on the weak pipe, less risk of it tearing or rupturing. Just manage the pressure.
But then came the TGF-beta discovery. That runaway signal wasn't just a bystander, it was actively causing damage.
Right. And that opened the door to targeting the chemical part of the problem, not just the physical stress.
Which is where drugs like losartan come in. The angiotensin receptor blockers, or ARBs.
Precisely. ARBs are standard blood pressure drugs, but in Marfan, they have this crucial other effect. They interfere with the TGF-A signaling pathway.
So it's not just about lowering blood pressure with losartan. How does it block TGF-beta?
Well, it blocks the angiotensin second receptor, which does lower blood pressure, but that action also has a knock-on effect of dampening down that excessive TGF activity. The aim is to reduce the inflammation, reduce the MMP activity, basically, stop the active chemical degradation of the aorta wall.
So you're trying to chemically protect the wall, not just lower the pressure inside it. What was the evidence this actually worked?
It kicked off with some really striking results in mouse models of Marfan. ARBs significantly slowed down how quickly the aorta dilated compared to placebo, or even compared to beta blockers alone. That was a huge signal.
Which led to human trials.
Yeah.
Comparing losartan against the old standard, atenolol.
Yes, several major trials were done, including large ones in children, and the results were compelling. They generally showed that losartan was better than atenolol at slowing down the rate of aortic root enlargement, especially in younger patients whose aortas were still growing faster.
So a real shift towards treating the underlying molecular problem.
A huge paradigm shift. Now, beta blockers are still important for managing the hemodynamic stress, but ARBs like losartan are often added or used as the primary therapy to target that TGF pathway directly.
But even with ARBs slowing things down, surgery is often still needed eventually, right? When does the aorta get too big, too risky?
That's a critical judgment call. ARBs buy time, hopefully delaying or preventing dissection, but prophylactic surgery replacing the weakened section of the aorta with a synthetic graft is often still required.
What's the trigger point for that surgery?
It mainly depends on the absolute diameter of the aortic root. Generally, in adults, surgery is recommended when the diameter reaches 5.0 centimeters.
5 centimeters, okay.
Though in smaller individuals, or if there's a strong family history of early dissection, or if it's dilating very rapidly, that threshold might be lower, maybe 4.5 centimeters. The goal of the medication and the close monitoring is to get the patient safely to that surgical point if needed.
It's a life-saving procedure when timed right.
Absolutely.
Let's just quickly go back to diagnostics. You mentioned nearly 1,000 different mutations in that FBN1 gene. That sounds like a nightmare for genetic testing. How is that handled now?
It is definitely challenging. You're hunting for potentially one tiny error, a single base change, a small deletion in a very large gene. So screening families or confirming sporadic cases needs powerful tools.
Which is where newer sequencing technologies come in, like next-generation sequencing, or NGS.
Exactly. NGS has been a game changer. It allows labs to sequence many genes, or even the whole FBN1 gene, much more quickly and cost-effectively than older methods.
So you can screen for all known Marfan-related genes at once.
Yes, often as part of a broader panel for connective tissue disorders. This really helps nail down a diagnosis, especially in ambiguous cases or in young children, before all the classic signs have appeared.
But what happens if the test comes back with something uncertain? A VUS variant of unknown significance.
Yes, VUSs are a major headache. It means they found a genetic change, but nobody knows for sure if it actually causes disease or if it's just a harmless variation.
So what do you do then?
It requires careful work. You have to correlate the VUS with the patient's actual symptoms, see if it tracks with the disease and other affected family members. Does everyone with Marfan signs have this VUS, and no one without symptoms has it? It often needs expert genetic counseling and relies heavily on the overall clinical picture. Technology helps, but it doesn't replace clinical judgment.
Makes sense. And just finally, reinforcing the importance of that TGF-beta pathway, there are other conditions that look a bit like Marfan, but the FBN1 gene is actually okay.
That's right, and it really underscores how central TGF-beta signaling is. For instance, there are mutations in the gene for the TGF-beta type 2 receptor itself, the molecule that actually receives the TGF-beta signal.
So the fibrillin is fine, the signal level might even be normal, but the receptor is overactive.
Exactly. Gain-of-function mutations there can cause a related condition, sometimes called Marfan Syndrome type 2 or MFS2.
Yeah.
They have similar features, especially the aortic aneurysms, but normal fibrillin.
The end result, the damage looks similar, but the initiating cause is different, hitting the same pathway.
Precisely. And similarly, mutations in another TGF-beta family member, TGF3, can also cause aortic aneurysms that look very much like what we see in classic Marfan. It all points back to that signaling pathway being the critical driver for the most dangerous cardiovascular problems.
This has been incredibly illuminating, really peeling back the layers from the outward signs right down to the specific molecular failures.
Yeah, to kind of wrap it up, Marfan syndrome boils down to a fault in the fibrillin 1 blueprint. This leads to a 1-2 punch. You get immediate structural failure because the connective tissue itself is weak, particularly in elastic tissue.
All right, the faulty scaffold.
And then you get this superimposed chemical signal overload from the excessive TGF activity, which actively degrades the already weakened tissue.
And the big breakthrough in treatment has been moving beyond just managing the physical stress with beta blockers.
To actually targeting that destructive TGF-beta signaling with drugs like ARBs, it's about trying to halt the underlying disease process itself.
Offering real hope for longer, healthier lives for people diagnosed today.
Definitely. The whole approach, from diagnosis using Gantt criteria and genetics to management with targeted molecular therapy, has shifted dramatically. It's driven by this deeper biochemical understanding.
Which leaves us with a final thought for you, our listeners. If getting to grips with the dual role of just one protein, Fibrillin 1 understanding it's both structural and regulatory, could unlock a whole new approach to treatment like ARBs, well, how many other common diseases out there, things we currently just manage symptomatically, are basically waiting for a similar kind of revelation?
What other conditions have a hidden molecular mechanism, maybe involving a protein we thought we understood, that's just waiting to be uncovered and targeted?
A really provocative question. Where else might that molecular precision be hiding?
Indeed. Food for thought.
Thank you for joining us for this deep dive.
We'll see you next time.